Dr. Jane Yanagawa is a thoracic surgeon in Santa Monica, California, and is affiliated with multiple hospitals in the area, including UCLA Medical Center and Santa Monica Medical Center. She received her medical degree from Baylor College of Medicine in 2004 and has been in practice for 15 to 18 years. She is board certified in thoracic and cardiac surgery by the American Board of Thoracic Surgery and the American Board of Surgery. She received Top Doctor Award by Los Angeles Magazine in 2021.
Thank you so much. Let me introduce our speakers, starting from this side, moving down. Dr. Alan Blank is an orthopedic oncologist at the Cancer Center at Rush University Medical Center. He specializes in the treatment of malignant and benign musculoskeletal tumors. He completed his residency at NYU, which was followed by a cancer fellowship at the Huntsman Cancer Institute. In addition to having a strong passion for clinical care, he also runs a very active sarcoma research group. Next to him is Dr. John Healy. He is an orthopedic surgeon at Memorial Sloan Kettering Cancer Center and specializes in caring for people with sarcomas and non-cancerous tumors of the bones and soft tissue. He has a particular expertise in removing tumors while preserving limbs and a special interest in treating children who have bone cancers such as osteosarcoma and Ewing sarcoma. He has been at Memorial Sloan Kettering since 1984 and has performed approximately 260 surgeries per year since then. In addition to his role as the chief of the orthopedic service there, he is a professor of orthopedic surgery at the Weill Cornell Medical College and has served as chair of the Children's Oncology Group Orthopedic Section, as president of the International Society of Limb Salvage, and as president of the Association of Bone and Joint Surgeons. He is also an advisor to the National Comprehensive Cancer Network. Next to him is Dr. Kenneth Wong. He is an associate professor of clinical radiation oncology at the Keck School of Medicine at USC. Dr. Wong has served on committees for the Children's Hospital of Los Angeles with the Keck School of Medicine and national radiation oncology professional organizations, including the American Society of Radiation Oncology and Radiological Society of North America. He has been a radiation oncologist for over 10 years and has authored or co-authored over 20 journal articles. Finally, we have Dr. David Ulmert, who is the Director of Preclinical Theranostics at UCLA. His research is focused on developing vehicles targeting novel biomarkers for multimodal molecular imaging strategies, as well as for carriers of therapeutic agents. Together with his team and collaborators, they have successfully invented, developed, and translated multiple radiotheranostic and immunotherapeutic technologies. Let's get started.
Thank you very much for the opportunity to present our research here. What a terrific conference, and the research that was just presented in particular, unbelievable. Congratulations. So this study we're going to present today is called the Prognostic Significance of Lymphovascular Invasion in Localized High-Grade Osteosarcoma. This idea kind of came about from our tumor board, actually. Most of our ideas for research questions come about from our tumor board. You know, at cancer centers, we all follow the NCCN guidelines, you know, to a T when we are able to, and you know, every center kind of focuses the discussion in tumor board, I think, on a little bit of different, you know, fringe topics. And this was one that we always talked about. It's not really in the NCCN guidelines or staging, but it's something that we've always discussed and said, you know, anecdotally, we think that these have different outcomes, and we finally decided to look at it and see if that was true. So none of the authors have any potential conflicts of interest in this. So we all know that survival remains 70–80% for localized high-grade osteosarcomas despite modern chemotherapy. You know, we certainly know that there are a number of factors that are associated with better or worse outcomes. These have been shown very well in the literature. However, we're not sure of all of those factors. I think over time, we're beginning to understand that some of these prognostic factors really have significant changes in outcome for these patients, and perhaps a better understanding of some of these lesser understood factors, such as lymphovascular invasion, can really help us to raise the plateau in treatment. So what is lymphovascular invasion? Lymphovascular invasion, it's simply the ability of these tumor cells to invade nearby lymphatic or vascular structures. It's been shown in a number of other cancer subtypes that these patients unfortunately have worse overall outcomes in both local recurrence as well as overall survival. Hepatobiliary malignancy, renal cell carcinoma are two particular examples of this. This image here, this is an example of what lymphovascular invasion looks like. You can see the arrow indicating the microscopic osteosarcoma emboli that have invaded these nearby lymphovascular structures. So although we routinely report this on our resected specimens at Rush, it's very likely that many institutions are not reporting it, and this was quite evident in the literature. And the question became, should it be a necessity to really document this invasion? So in looking through the literature, there were really only 5 studies that we could find that had any documentation of lymphovascular invasion in these osteosarcoma cohorts. These are them listed here. However, only a few of these studies actually assessed lymphovascular invasion as a primary variable of interest. Many of them were just an afterthought or a secondary or tertiary variable. Furthermore, only one of these studies systematically reviewed their slides as part of the histopathology review. So none of them went back in time and looked at all of the slides to actually see did the specimens that we said didn't have LVI, did we just not look for it? So this was the idea behind our study. We set out to do that, and we looked at our cohort over that period of time, and at the end of the day, we had 42 patients who met all of our inclusion criteria. 9 of these patients had lymphovascular invasion. So of note, the slides from each of the resected specimens of those 42 patients were re-reviewed by our pathology team. And that's really what's unique about this, just to confirm that those other patients didn't have lymphovascular invasion that just was not reported. So what did we see in the results? Well, we looked at the survival of the entire cohort, and you can see the 5-year estimated probability of survival was 81% for the entire cohort, which is really right in line with the historical plateaus that we were talking about. You can see it there on the Kaplan-Meier curve. However, in patients with lymphovascular invasion, we noticed a significantly different outcome on the Kaplan-Meier with an estimated 5-year overall survival of 40%, which is obviously drastically different. So we then utilized a proportional hazards model of regression, and you can see that the final model, the presence of lymphovascular invasion was associated with a worse prognosis, as was advanced age, which is a known negative prognosticator. Similarly, you can see that patients with lymphovascular invasion had a much worse recurrence-free survival, as shown by that graph there below. And finally, we utilized a competing risks analysis to test the association of lymphovascular invasion and the incidence of mortality. And you can see from the panels A and B that there was a statistically significant association between the presence of lymphovascular invasion and a higher mortality risk. So in conclusion, we have found that the evidence in the literature to show that these patients have a higher risk of death and worse overall prognosis. And as such, we routinely report lymphovascular invasion on our resected specimens. We hope that those institutions who aren't currently reporting it should consider reporting it. Lymphovascular invasion, we believe, is really a critical portion of what should be incorporated into the staging of these patients, since many of them, the outcome seems to be drastically different when they do have LVI. And what about future directions? How does this change the practice management? Hopefully we may be able to identify this LVI before systemic therapy or before local control surgery, although there are certainly challenges. As many times it's only identified on larger specimens, right? The final resected specimen, it's very challenging to find LVI on smaller samples. It can potentially be done with advanced imaging techniques or novel biopsy techniques, but again, some of these new techniques are not validated in osteosarcoma. At the end of the day, we likely need more evidence for LVI in osteosarcoma. Currently, it's not a standard element per the College of American Pathologists, nor is LVI required for osteosarcoma staging. I think in order to investigate these changes, we likely need more multi-institutional evidence to show that this is true across all cohorts. So thank you once again. It's really an honor and a privilege to be here. Take care.
Okay, I'd like to thank our moderator, Christina, and the whole organization for another outstanding meeting. And I'll be discussing the local control of osteosarcoma in somewhat of a generalized way, selecting particular examples from different anatomic locations. And it's a broad survey and not a nice study like Dr. Blanks that he just presented. And I thank you all for your attention and being here for this session. The large green, I understand. I am a consultant for the Stryker company. All the implants I'm showing are going to be from the Biomet company, and I have no prejudices. The outline here will be, why do you need local control, and some of the interrelated aspects of chemotherapy and surgery, and then elements of the various examples of different reconstructions that we'll look at, compress issues in the proximal femur, reverse shoulder, and bone transport. And so why is margin important? Well, it's very important in terms of local recurrence. It's also highly correlated with systemic results, and it's not entirely clear whether that's a causative thing or not. We just heard a beautiful presentation on the importance of lymphovascular extension, and in essence, that's almost the equivalent of a metastasis to the lung, if you look at those numbers. And indeed, in Dr. Blank's presentation, he referred to them as emboli within the vessels. And in fact, they are certainly venous transmission, be it in continuity or as a separate focus. And so I think that's an apt expression and description. And I'll try to show you that there's a reciprocal relationship between the responses to chemotherapy and the presence of the result of local recurrence. Now, in the UK, recently, Lee Jays has tried to look at this relationship between the margin of resection and the response to chemotherapy, and it's depicted in very careful analysis of their resection specimens as illustrated here, and trying to quantitate the specific thickness of the margin. How far away are you? And when I come out from the OR, I can speak to you parents and say, as best we can tell, we got it all. And so looking at that margin is important, not just yes or no, cells at the margin at the ink or not, but trying to assess the thickness of that margin. How much is enough? And the other aspect is the necrosis within the tumor, with which you're familiar, but I'm going to elaborate more on that. Now, their results are in the top panel, and I'm going to compare that with the results in the largest series from the Rizzoli that predated it. But it tries to capture these two elements of the extent of necrosis, and based on the inflection point of 90% or not that Huvos and from our institution first advocated and promulgated. And the second is a thickness of margin, which they identified their inflection point as a 2 millimeter margin. And on the top panel, again, if you look on the far right, at the relative risk of local recurrence, well, if you have good necrosis and a good margin, relative risk 1. And as the situation deteriorates in terms of chemotherapy response and surgical effect, it goes up. And so ultimately, bad response, bad margin, 20 times the likelihood of local recurrence. And I take the Rizzoli data on the bottom and make it the equivalent of a traffic light. And for all of you driving, you come up and you see a yellow light. Well, what do? Do you step on the gas and get through? Or do you slow down, are you cautious and take a conservative approach? And so in this instance, again, poor chemo response, less than a wide margin, 46 times the recurrence rate at Rizzoli. And if the yellow lights are where I think we have to make clinical judgments, and do we go for a bigger margin? Do we switch and decide to amputate, for example? And these are very important questions. And from leading fellowship training centers in the United States, they're reporting 14, or even another study, 20% local recurrence rates, which in my mind are inadequate. And I'm sure in yours as well. And ours historically was 3.7%. And it makes a difference because only 10% of the children who get local recurrence will ultimately live. It's still worth trying, forging ahead, and why we need additional treatments. Now, why is there bad response in the primary tumor? And I think it has to do with physical and chemical impediments to drug delivery. And in this example, and so you'll see my experimental work is some in mice, some in dogs, and ultimately the final arbiter is in people. But here, you look at distribution of drug is seen in the ink, and the whole periphery gets drug, but the central area doesn't. And this is a mouse model, and subcutaneous in the back. But by decompressing the tumor, taking out a mere 1/10 of a cc in fluid because of the bulk modulus and the fourth power pressure measurement, now the entire tumor is perfused and drug distributes. And in therapeutic trial they did in dogs, we looked at this, and we have the only example in the world here looking at the central panel, which is a method called the Spaltholz technique. And so there you infuse sub-micron particles of dye. So a red blood cell, 7 microns. This is 1 micron. And so they distribute anywhere a blood vessel goes. So you see these vast areas in the middle of the dog osteosarcoma that are devoid of that perfusion you seem to think. However, when you go and stain, we heard earlier about CD31 staining for vessels, and there are actually more vessels in that area even though there's no perfusion of it. And why does that happen? From the bulk and the actual mechanical, physical weight or mass of the tumor. And it's there's no way that you're going to get necrosis if you can't get the drug there. Or it relies on not direct delivery or even diffusion, but requires convection. And large molecules like antibodies have to go by convection, and they can't make it there. So you need, and we hear beautiful presentations about nanoparticles, viral things that can sneak their way in with, with the onion strategy. But these are important. Now, in terms of reconstructions, I'll show a few examples. Some people say, well, in New York you have small tumors, and I say, well, sometimes, but I also take care of the third world country called Brooklyn, and this is an example of the one of their tumors, and they're big, ugly things. We preferred reconstructive method. It was developed at UCSF, and it's based on spring loading and compression that stimulates bone formation and osseointegration. This is a long-term follow-up of 14 years on one such patient. And it's called a compress device, and at the interface it stimulates bone formation rather than atrophy of the bone, which happens with cemented implants and all. And this is our survival curve for these implants, which is better than any other published results. Chemotherapy, necessary, can't live with it, can't live without it. It interferes some with the integration of my implants. We do some complex reconstructions. These are very creative enterprises. I'd encourage people to read the best-selling book that my patient Bruce Feiler wrote, and Council of Dads, but this is his case. of 12 years of long-term follow-up, and it's with customized integration in very short segments, and I back it up with vascularized fibrillograph, so it created a 2-lane highway instead of one. It dissipates torque and rotational forces, and it's very successful. Growing prostheses are the thing. Here's an example, and this is also an example of Dr. Blank's presentation. There's a significant vascular invasion of this tumor, bad histo response to pre-op chemo, and a customized implant that you see it's an extensible one and is humerus, and a custom reverse shoulder, which is great, and he's doing well and doing actually even heavy work with it. That was an invasive type of extensible prosthesis. The non-invasive method from Stanmore in England and has been transported here. But the main publication is only on 44 patients. They had a 29% complication rate, 18% needed ultimate revision. But it's great because you can do it as an outpatient. It doesn't take long. Doesn't need anesthesia. It's actually quite remarkable. There are some concerns about MRI compatibility, but that seems to be okay so far. But there are other problems, even with these extensible ones, and this is an example of one of my patients who had necrosis of half of the tibial plateau and required separate innervation. So we lengthened his femur and matched his limb length, but I had a separate problem that had to be addressed. And finally, our latest thing is in bone transport. My partner, Dan Prince, is presented here before. I'll summarize it. It's basically for intercalary mid-segment resections, trying to save the joint, not just the limb, but the joint above and below. And so when it's in the middle of the bone, that's pretty easy and well understood. When you're into the epiphysis, and basically if we can save 1 centimeter of the articular surface, we do so, and use existing bone and transport it, drag it through the tissue, and in its wake it creates new bone formation. And there are different ways to do it with these outriggers, the erector set on the external, or more recently the major play is with what's called a precise nail, and so that's a closed procedure, again extending it. And it even works with chemotherapy, but it slows down the bone regeneration. And the outcome is achieved over the course of 2 years, and then you don't have an implant or an allograft or things that would fail late. The final point now as a participant is many of us who are in a major international study trying to address prosthetic infection. Dr. Gert spearheaded this, 604 patients. And I draw your attention to the bottom line, which is still tragic. Between the two different antibiotic prophylactic regimens, 16.7% and 15% infection rate. And I would contend that I can cure cancer better than I can cure infection in these. And so we still have a big problem to address. So in conclusion, limb preservation is possible in 85% of cases. It requires innovative techniques. You need to have good margins to prevent recurrence. Advances in osteointegration and bone regeneration are extending the indications and saving joints and not just limbs. But we still have problems with growth, disturbance, and infection. And thank you. Sorry for going over.
Well, thank you to Christina and the organizers for allowing me to present at this meeting. Let's see, this is my first in-person meeting since the beginning of the pandemic, so I'm a little rusty. So I'm speaking a little bit generally about radiation. I'm talking about the considerations for planning radiation therapy in pediatric and adolescent and young adult patients with sarcoma, as well as osteosarcoma. And so this is one of my favorite photos. This is the closest photo I could find of San Diego, but this is Crystal Cove in Newport Beach. And the point of this slide is to say that radiation is a natural phenomenon, exists all throughout nature. I was a little bit, looking at the rocks to the left, I was a little bit shocked to learn that in my house, in my crawl space, I have high levels of radon. So it's something that I'm going to have to figure out about. So radon exists in nature. One of the, we're moving towards a future potentially where we can use solar energy, and there's a lot of energy that can come from the sun. So on this bright sunny day, we're exposed to visible light as well as UV light, but also cosmic rays. So let's think about radiation on the atomic scale. This is something that I just drew up. So anybody who's a scientist out there, don't shoot me. It's not an accurate model, but I wanted to show that in the atom there's a nucleus with protons and neutrons, and orbiting that are electrons. So in this very simplified model, we basically have electrons and protons. Neutrons and carbon ions, those are italicized because there are types of equipment that can deliver these forms of treatment, but they're not very commonplace. So in the United States, by and large, we're talking about proton therapy as well as electron accelerators. And electron accelerators can be converted to X-rays. So if you have an electron machine, you also have an X-ray machine, but proton machines are completely different. So I think by now most people are familiar with X-rays and CT scanners and MRIs and PET scanners, but I wanted to show you a little bit of what's underneath the cover. So we've got a gantry, there are a lot of mechanical components, electrical components, and computers. For radiation therapy, this is where it all starts. We need imaging to determine exactly the size of the tumor, the location of the tumor, proximity to normal organs. And when we plan radiation treatments, we plan off of CTs, MRIs, and PET scans, but we always have to have at least a CT scan, and we can combine these with other forms of other forms of imaging like MRIs. So once we have imaging, what do we do next? Well, I wanted to show you two examples of machines. On the left is our machine at CHLA, which is an X-ray machine. And to contrast, here in San Diego, California Protons has a proton machine. If you haven't seen these machines in person, if you'd like a virtual tour, we have a virtual tour at our website, and as does California Protons. Protons are about 2,000 times as massive as electrons, so you can imagine that the machinery required to accelerate a proton would be much more massive, I guess. And that you can see in this photo. So this is where I work in Hollywood at the Children's Hospital. The image on the right is the control panel where we can control the machine. The nearest desk belongs to an anesthesiologist. All of this is just to say that radiation therapy really requires a team effort. So this is a picture showing the innards of our linear accelerator. We've got some engineers and physicists and other scientists who are involved in calibrating this equipment to make sure that our treatments can be the most precise as possible. And here you can see that they're using equipment to make sure that we're able to accurately pinpoint our radiation treatment. So here's a focused view, and they're using Starrett micrometers and torque wrenches and levels to make sure that we're really precise and really anal about calibrating this machine. And this is on an X-ray machine, but likewise you'd see the same level of attention to detail for a proton machine. So what can we do with this machine? So Dr. Olch is a medical physicist. He is in the office right next door to me, and we were able to use our machine and print this picture using X-rays. So it kind of tells you, like, wow, the technology that we have is really impressive. The very first time I saw this, I thought, this is really cool, I've got to share it. But over the years, as I've looked at it more and more, it's given me these other questions, like, how can we improve on this picture? And I think it's like some of these TV commercials that I've seen, but is it possible to make, in this picture, the blacks blacker or the white of the collar of her shirt whiter? And you can kind of see that it's a little bit low resolution. Can we improve on the resolution? So that's where a lot of the research in radiation is directed towards making our equipment better, more precise, higher resolution. But ultimately, what we really need to focus on are patients. So showing you how a patient is positioned for treatment. This is a patient who's positioned for treatment of a tumor in the brain and in the spinal cord. So we've got immobilization devices, which are really basically molds so that we can make sure that patients are positioned in the same treatment position day after day for treatment. And in this case, the patient's head is directed towards the machine. But if a patient has a sarcoma of the extremity, then we flip them around and then their foot is pointed towards the machine. So we talked about the head and now the other end. What about in the middle? I hope this works. I was reminded by one of my students to remind you that all of this attention to detail is to ensure that we can treat the tumor and to protect the surrounding healthy tissue. So we know that if there's a tumor in the chest, for example, we have movement. Let's see if this works. Yes. So we have a technology called 4D CT. So we can do a CT scan and we can see the diaphragm moving up and down. In this case, we're trying to target a tumor that's in the upper left chest, and we can see that's really not moving much at all. But what if we were treating a tumor that's closer to the diaphragm? Then we have to account for that, and how do we do that? One way is to try to track that movement, but it's very difficult. So if a patient is really compliant, we have another method called deep inspiration breath hold, and what you're seeing on the upper left is an outline of the patient. So we know this is exactly the position that we want the patient to be in. In the lower left, you can see the position of the patient as he's just breathing normally, and then on the right, what we've asked the patient to do is to take in a very deep breath, and as the patient takes in that very deep breath, now we know that the radiation is going to go to exactly the place where we need it. And by holding the breath, we've stopped one of the motions. Incidentally, if the patient starts to breathe and move, the radiation will immediately pause. So, but radiation, after all, still has its limits, and I think it's appropriate that I follow the surgeons because we typically don't treat radiation, but there are some other indications. So a tumor like this massive tumor, really radiation, we're really unable to help a patient like this. But this is a patient who's had a surgery, and this is someone that we can help. And this is a patient that had a positive margin. And learning about lymphovascular invasion and margins, it's really critical in our field. We talk about margins that are millimeters, but to help me visualize that, I imagine the thickness of a penny. If you stack 2 pennies, we're talking about 3 millimeters. So that gives you an idea, like if tumors are that close, then there's a higher risk that tumors can recur. So in this case, it's really important for us to know about the material of the implant. So, for instance, if we have a Stryker implant, I would call Stryker to find out what is this made out of. Is it cobalt? Is it chromium? You know, these things really matter to me to design the best possible treatment. I talked a lot about x-rays because that's the machine that I have, but I collaborate with my colleagues here in San Diego quite a bit. And this is a patient that was treated in Los Angeles, but then the patient had a recurrence in the lung. And after surgery, we thought this patient could benefit from radiation treatment. And in looking at the scans, I thought, okay, what's the size of the tumor? Where is this located? What is the risk of radiation to the lungs or to the heart? And we thought and discussed and said, you know, this patient could possibly benefit from proton therapy. And so this patient was referred down here for treatment and was treated by my colleague. You can see that in this picture, the radiation is still going through the left rib, going through the spine and the spinal cord, but you can see that the dose to the heart is extremely low and could really limit the late effects that this patient may experience. Unfortunately, a few years later, this patient, who's from Orange County, came to LA and had a new symptom. He had a weakness of his left arm. And then on imaging, we found that he had a new tumor around the upper portion of the cervical spinal cord. In that case, to avoid paralysis, we needed to start radiation right away. Looking at the size of the tumor and the location, we felt that we could safely treat this patient and still protect his brain and other organs. So we treated this patient with x-rays in Los Angeles, and he's still doing pretty well, and it's been about 5 years since his treatment. Here's another patient with osteosarcoma who had multiple lung and chest wall recurrences. He was treated with surgery, chemotherapy, and immunotherapy. And over a period of about 9 years, he received radiation 4 times to his chest, many times after surgery and chemotherapy. And you can see that we treated him with conventional radiation, which means treatment 5 days a week over a period of about 6 weeks. But then other times we used another technique called stereotactic body radiation therapy, where we're giving much higher doses of radiation. So we treated him in 2011, 2014, and then again in 2017 and 2019. So this highlights that radiation can be very effective in controlling tumors, but only in the local area where we're directing the radiation, and it doesn't really prevent the potentially new tumors from popping up where we didn't give radiation. So This is another patient who got stereotactic body radiation, which is a much higher dose. And I'm just showing in this case how the tumor is being treated with this technique where the machine rotates around the patient. The machine rotates at 1 RPM. So this treatment, we did 2 passes, so it takes 2 minutes, and we're giving much higher doses of radiation than we normally do. And I'm also showing that in this case, we used a PET scan to show exactly where to treat the tumor. And the right leg obviously is not the area of concern, so you can see that his right leg is lifted up for treatment. The PET scan doesn't match, but what I've done is I've focused on the left leg and made that match perfectly. And finally, in the interest of time, I'm going to show you this one slide, and it's a YouTube video that I'm really excited about. And it's this potential new form of therapy called FLASH. It's still not ready for clinical trials broadly, and we're not using it in children yet, but I think this is an interest that many people are talking about in radiation therapy. So we talked about conventional doses of radiation, which is 1.8 or 2 units of radiation per day. We talked about stereotactic body radiation, where we're using much higher doses each time. But what if we were able to deliver that amount of radiation super fast? Instead of 2 minutes, what if it's delivered in terms of milliseconds or microseconds? Like blinking your eye takes about 1/3 of a second, and what if we deliver the radiation faster than you can blink your eye? And we think by doing that, there may be some benefits in protecting the normal structures of patients and improving outcomes. So with that, thank you. I appreciate your attention.
Thank you so much for giving me this opportunity to present my data here today. And thanks to the organizers for organizing a fantastic conference. So my work on constructing this radioimmunotherapeutic application started about 4 years ago. We set out to specifically look for mesenchymal-derived tumor tissue. To make a very long story short, we single out LRRC15, which is a plasma membrane protein, and it's driven by TGF-beta. The role in normal tissue is relatively understudied, but we know that it has something to do with cell migration and communication. Here on the upper half of this slide, you can see that in green boxes, that's the normal expression in normal tissues in the genomic database. This is one of the databases they've used. On the right, you see in red, that's in malignant tissues. On the bottom of this slide, you see immunohistochemistry stains, where brown is LRRC15. And you can see that we have very low expression in normal tissues. We have in hair follicles a little bit of LRRC15, but it's basically unexpressed. However, in tumor tissues, we have really high expression. What's relatively unique with LRRC15 is that it can either be expressed in the stroma only, and it's not expressed in cancer cells. What has been shown by Genentech after we sort of started to investigate this is that Turley's team published a fantastic article in Cancer Discovery where they show that LRRC15 is specifically expressed in PD-PDL1 and CTLA4 tissues, and they looked at pancreatic adenocarcinoma and also malignant melanoma. However, in some diseases, like osteosarcoma, we have actual expression in both the stromal tissue and in the cancer tissue. So theoretically, 100% of the tumor express LRRC15. So we investigated this further as if LRRC15 is a biomarker together with Hornacek's team at UCLA, and we utilized a database where we looked at primary biopsies in osteosarcoma patients, and we looked at the intensity of the stain, and we correlated that to survival. And what we found is that LRRC15 was correlated to aggressive disease, treatment resistance, and short overall survival. So we made an antibody that is then specifically targeting LRRC15. We humanized it, and you can see here on the left that we then evaluated in using flow cytometry, using a wealth of cell lines with different wild-type expression of LRRC15. We also used knock-in and knock-out cell lines. To the right, you can see confocal microscopy live stains in room temperature, you can see that it specifically is found in the plasma membrane. We also evaluate the number of available targets per cell in the plasma membrane that our antibody can detect, which is called DUMP19. And we see that the number of available antigens, which is up to 1 million, 1.5 million per cell, correlates with the expressed the expression of the LRC15 in the tumor. Here is then when we look at the antibody further, and we found that the antibody is internalized, which is key when you are utilizing an antibody for ADC, whereas in case of how we're going to use it is for radioimmunotherapy, because you can potentially use alpha particle emitting radionuclides as well as beta. So the concept of radioimmunotherapy is that you take an antibody or a peptide or a small molecule and you radiolabel it and use the antibody in this case as a vehicle for specifically targeting tumor tissue and delivering radioactivity to the tumor cells. When we also found that the antibody has a very high affinity, so picomolar affinity, and is not affected by radiolabeling, here shown when we radiolabel the antibody with lutetium-177, which is a beta emitter that you can also then image the location using SPECT. Here are a couple of examples in subcutaneous tumors. We used HU9-SOS2, which are osteosarcoma, and then also added U118, which is a glioblastoma tumor. We have very high expression and uptake in these tumors, up to 50%, which is very high. And the antibody uniquely behaves that it's washing out in all other tissues that is not having LRC15 expression. When you utilize bigger antibodies, you usually see you used to see that the antibody is broken down in liver and spleen, but we don't see that at all. Also, I would need to mention that the antibody is targeting a phylogenetically stable epitope, meaning that we're targeting both murine LRC15 and human LRC15. Here is an example when we take the antibody and we radiolabel it with copper-64, which is a positron-emitting radiometal. So we injected the radiolabeled antibody in the tail vein of an SOS2 carrying mouse, and you can see that the antibody is then taken up specifically where you have the subcutaneous tumor and is rapidly taken up. We also evaluated to make sure that the antibody is internalizing in vivo as well as in vitro, as we saw before. You can see here that what we did is that we took the antibody, we labeled it with Cy5, and we injected it to the mouse and in the tail vein of the mouse, and we harvested the tumor 72 hours later. We sectioned the tumor, and then we did confocal microscopy, stained for LAMP1, which is a lysosomal marker, and we see that we have an overlay between LAMP1 and DUMP19, which is the LRC15 antibody. We also stained for DNA and actin to see what the relationship are in the cells, but it's clearly internalized in vivo as well. Here is then when we utilize the antibody for therapy. So the particle that we used here is that we took the antibody and we radiolabeled with lutetium-177, which again is a beta emitter. And we tested what happens in an HU9 model when we start the therapy, one dose, relatively low dose, and when the tumor is small versus when the tumor is larger or large, and then compared it to non-treated tumors. And you can see that we have a very good effect with one shot in small tumors. We have a lesser effect when the tumor is large, which is normal. We're also currently evaluating by RNA-seq different time points after therapy when we have done the injection. We then evaluated when we give multiple fractions of low-dose lutetium-labeled DUMP19 antibody, and it's well tolerated, and we see that we have a very good effect, anti-tumor effect. Here is what we saw, as you probably notice here, is that you have a little bit of volume left, and we were evaluating to see do we have a lot of calcium deposits in this tumor, and what we see is that when we look at SPECT-CT, when you have just injected the antibody the first time you inject the compound, you see that you have a nice uptake and not that much calcification, but after 2 more shots, you see that you have a huge calcification or calcified tissue. So most of the tissue looks like it's dead when we evaluate it by H&E. Let's see. So we also did an orthotopic model, and you can see here when we inoculated in the tibia, it's a very, very small tumor on the micro-CT. Regardless, 72 hours after injection in the tail vein, you can see that the antibody is specifically taken up and has very high uptake where the tumor is located. We then utilize this sort of, the good thing about using theranostics is that you can use it for both diagnostic purposes, treatment planning, and evaluating the treatment effect. And as you can see here is that we took then orthotopic models, we injected with lutetium-77 labeled antibody, we imaged with SPECT-CT to evaluate the sort of extent of the disease and the dose that you actually get to the disease by quantifying the uptake. And then we waited 160 days and we re-injected a new dose of the lutetium-177 labeled antibody. We did a new SPECT and CT. And as you can see here that after the first dose, you see that you have a good uptake where you see where the tumor is located. When we inject it again and did a new SPECT CT, we see that the tumor is gone. And this study is actually still ongoing, and we see that the mice that were injected doesn't seem to have any disease, residual disease left. So in summary, we have made an antibody that specifically targets LRC15, very high affinity, it's internalizing, targeting a phylogenetically stable epitope, and we have humanized antibody. It looks like it works really well for osteosarcoma, but we also have other cancers that I'm not showing you here, and we're looking to translate this to humans, and we need help with that. So whatever you can help out with, we're very thankful. Thank you.
All right, I think we have about 20 minutes for questions. Did we get any online? Anyone? Okay, we can start with the audience.
So we are going to take questions now for the next 10 minutes, 20 minutes. Next 20 minutes, we'll cut into lunch a little bit and return back at 1. Are there any questions for the panel?
Thank you. Great talks, everybody. For the LRRC15 antibody, do you see downregulation of that antigen? Have you seen antigen loss following repeat administrations of that antibody?
One more time, please. Sorry.
When you've been giving repeat doses,
Yeah.
or even just a single dose of your antibody, do you see downregulation of LRRC15 or even epitope loss?
That's a great question. We don't see that we have a downregulation. However, which I didn't show here, that we have other subcutaneous tumor models that we utilized. What we see is that in some of the models, we see that the tumor is usually very aggressive, but after treatment, we see that it reaches sort of a senescent state. And we don't know why. And we're currently evaluating that with proteomics, RNA-seq, etc. And that's what's left before we publish this study. Great question.
Hi, this is a question about lymphovascular invasion. Dr. Blank, I think. Do you have any plans for validation studies? Meaning, you mentioned that this would be good to confirm in other populations.
So we're working with a couple of other institutions to try to get a larger cohort. I think if we can reproduce the same results that we had, it's worthwhile to think about classifying this cohort differently. Not that we currently have any more aggressive treatment to give these high-grade tumors, but they'd be kind of a prime candidate for studies. So if we can get a triple-size cohort that matches our outcomes, I think that's the next step.
Have you considered collaborating with one of the national banks, for example? And can you use bank samples, like samples that are already put away in a biobank?
We could. I think there's a couple other hurdles to overcome for that, but currently we're we're just working with 4 other institutions that we do a lot of work with, just because they have kind of direct, one person removed access to grab the samples and physically look at them. But that's a good idea.
Great. We can talk more later.
Yeah.
But if you don't have the gross samples, you're going to miss them. And so the tissue from the center of the sample is going to miss that commonly, I would think. But I think it's a very important observation, might add, and you can extrapolate from other tumors. And so, Michael Aqualia and I found that was an important aspect in synovial sarcoma in pediatric population, for example. And so in other diseases, it has been shown, and I think makes good sense here and is worth doing it. It's one of the prognostic factors from the Scandinavian Sarcoma Registry across the board is one of the most powerful indicators. And so I think, personally, I use it as I stage my patients, and I think this is a brilliant effort to prove it.
Hi, I have a question about the LRRC15. So first question is, when we looked at the levels, it's very high in some osteosarcomas, but not so high in others. There is some heterogeneity, and I'm just wondering, that's my first question, have you looked at because it may be a selection would be really important, or have you tried, I don't even know if there are xenografts where you could do a lower expressing tumor and a higher and get some sense of the cutoff. And my second question, just quickly, is, I think in many ways what would be much more interesting, I'm sure Dr. Healy could tell you the size of the tumors you're treating in mice, he could cure no problem just taking the tumor out. It's the big pelvic tumors or a big shoulder tumor, big tumor, that the surgery is really difficult. I wonder, have you looked at how big can the tumor get, and it can still be effective? Because I think what we really need is for those big unresectable pelvic tumors that we do terrible trying to cure with surgery and chemo. And if this could really deliver specifically, 70 gray to just there, we could cure some of those patients, I think. But Dr. Healy can't cure them with surgery, and we can't cure them with chemo. So I'm just wondering, how big have you looked at the tumors? Those are my 2 questions. Thanks.
So I'll start with the last question, and that is, we looked at tumors that are about almost a centimeter in size. And we see effect, and we see, I didn't show the data here, but we do see gradual when we repeat dose. The dose limitation with lutetium-177, because it's a beta, is that you get bone marrow effects on the bone marrow. Because pandemic, we couldn't get actinium-225 because there's a shortage of it, and I think that's probably a much better radionuclide to use, because you don't have the effects with bone marrow toxicity.
What is the emitter?
Alpha.
Beta?
So lutetium-177 is a beta,
Right.
and then alpha is the actinium-225. We also tested with thorium-227, but that has to do there's some problems with the labeling efficiency with the thorium-227. Bayer has sort of their radioimmunotheranostics program. They were the one who patented the thorium-227, and they have sort of nixed the program now.
What dose are you seeing in the tumor?
It's then 50% of it's like with alpha, it's 50 to 60% of what you injected. But then the other question, when you see that you have variability of the LRRC15 expression, that's a great question. There are osteosarcoma cell lines that we've utilized that has, like U2OS has a lower expression of LRRC15, for example. We haven't tested the efficacy in osteosarcoma that has a lower LRRC15 expression, but we've tested it in other like GBM tumors and malignant melanoma. We do see an effect. But like, then again, another thing that we're doing in my lab is that we're looking at what actually regulates and what affects the TGF-beta regulation, because it's something iffy going on, and we utilize HTS and single-cell RNA-seq to figure out what mutations are causing TGF-beta in some cell lines to upregulate LRC15 and some not. And we will probably have an answer in a year or so, two. But yeah, and I don't think that it's going to be, I don't think it's going to be a magical bullet still. I think you hopefully have really good effect, but we probably need to combine it with other therapeutic modalities as well. So we'll see. What's good with the antibody is also that you can see where the tumor is located, and I think that hopefully can help surgeons to locate potential metastases that are resectable. Yeah.
Thank you. Any other questions for the panel?
May I ask, if this is localized in the matrix so much, why aren't there off-site areas of localization? I mean, the matrix must, there's nothing unique about the matrix in osteosarcoma. I would challenge you to decide a difference in the matrix in regular bone compared to osteoid and osteosarcoma.
The difference between LRC15 expression in normal bone versus
Yes.
osteosarcoma.
Yes.
You don't have an expression in normal bone.
Well, I know, I showed that, but I don't understand why. If
that's
it's
a great-
labeling,
that-
if it's
it's a-
labeling the matrix so much.
That's a very good question. And it probably has to do with something with TGF-beta driven clones, because that's what, again, Turley's group have seen. There's a fantastic paper, you should read it. And there they follow these GEM models with pancreatic adenocarcinoma GEM models, and they follow and look at how TGF-beta, some cell lines and some islands of cell lines, they take over, and they're specifically driven much better with TGF-beta compared to other calves, for example. But it's a great question, and I wish I had the answer.
Thank you.
I have sort of a related question, but if you think about it, Theranostics is essentially a systemic therapy, and so it'd be really amazing for metastases. And all of your data looked like it was sort of focusing on primary tumors. Do you know if the staining pattern is similar between primary and metastases, or even between metastases?
That's something that we're evaluating. Yes, so the models that we have utilized to start with are it could either be metastases-derived cell lines that we utilize, but that's not, a cell line is a cell line, and the model is a model, and the mouse is a mouse. But yeah, we'll see. I think that that's why we need to, the beauty of radioimmunotheranostics is that you can inject an antibody at trace levels. You can decorate it with, zirconium-89, for example, that is non-toxic. And you will then evaluate, how many of the metastases compared to normal anatomic imaging that you see the uptake in. So we'll see.
May I ask Dr. Wong? And so until you get flash available, you're basically the ultimate hypofractionation, basically. How do you see that affecting beneficially for your radiotherapy? And secondly, do you use anesthesia and just controlling the respiration to keep your fields perfectly still? And if you're doing hypofractionation, it's only a couple of treatments, and so a couple of quick anesthetics is probably quite safe and effective.
Those are excellent questions. We think about that a lot, especially for patients that are borderline. We will use anesthesia. We currently have anesthesiologists in our department every single day, so roughly about a third of our patients require anesthesia. Some of those patients are just very young. Others, we make that decision we could use this technology to try to target the tumor better, but it might be better just sedating the patient, especially if we're not treating them that many times. So yeah, we make that decision quite a bit. the second part, even controlling that respiratory motion when we're treating around the lungs and the heart, the lungs are so sensitive, and especially in that patient that I showed that got
So the
4
heart's still working.
treatments.
Yes.
It's working, but the quality of the life is just not the same. You know, the patient was a tremendous athlete, and after we caused the fibrosis from surgery and radiation, it's not the same. So we're hopeful that FLASH could mitigate some of those effects, but your point's very valid. I mean, maybe the benefit could be, there are some very rough estimates, maybe 30% improvement in terms of side effects. So it's not going to be a patient who will not have any side effect. And so other than that, we think about other types of radiation like brachytherapy or radioimmunopharmaceuticals, because they can deliver very high doses of radiation locally. Like for instance, we've seen patients with malignant pleural effusions, and external beam radiation I don't think has a very good answer for that, because it just causes so much scarring.
I mean, it makes a difference what margin you take when you're taking out that pulmonary metastasis. And so it's in terms of the residual lung function, and it makes a difference in what margin you take on the radiotherapy for it as well. And so if you can narrow that effectively, I would think it's a good idea.
I have a radiation-associated question. You talked about PET-guided and CT-guided radiation therapy, but I think I've heard MRI-guided radiation therapy. Is there a role for that here?
UCLA has an MR linear accelerator. So in our center, we use, at CHLA, we have separate MR scanners, separate PET-CT scanners. So we take these images, match them digitally, and then direct the radiation treatment. But there's always that gap in time. You know, the PET scan may have been done a week before. The advantage of having a combined machine like UCLA, where they have an MRI and a linear accelerator, is you can get a real-time MRI, or as close to a real-time MRI, because you're doing it right before treatment. So there are some advantages, and it goes back to that margin. You know, if we're getting a real-time MRI, instead of using maybe a 5 millimeter margin, maybe we can cut that down to a 2 millimeter margin or a 1 millimeter margin, and that protects the healthy tissue.
We have another question down here.
This is probably a naive question. Does FLASH induce immunogenic cell death?
Could you repeat the question?
Sorry. Does FLASH proton therapy induce immunogenic cell death?
I don't know enough about that, because I think FLASH is a really, it's in very early stages. FLASH just implies giving radiation very, very quickly. We can do it with electrons, protons, X-rays. I think that it can help protect tissues. We've seen that. And it doesn't spare tumors. But then in terms of the hematopoietic system, I'm not 100% sure. The YouTube video that I linked, one of the researchers, Dr. Lamoli, he's at UC Irvine, so he's relatively close. Some of the other world experts are in Switzerland. So that would be a fantastic question. I know that we're working towards clinical applications. There has been a patient treated in Europe, and we're working towards clinical trials here in the US.
Any other questions? One more.
Do we know why the quick dose of radiation in FLASH radiation therapy spares the healthy tissue and still targets the cancerous tissue?
Again, I'm totally not an expert. There are many people who are way smarter than I am. There are people who specialize in radiation biology, radiation physics, and these things are happening at such small time scales that it's so hard to understand. There's some hypotheses that maybe it has to do something with an oxygen effect, or maybe something on the vasculature at a very small level, but I don't understand how you can deliver such large doses of radiation so quickly and yet have these beneficial effects. So to me, it really is a mystery, and as a clinician, I'm someone who would apply some of these things that are learned and studied by people who are far smarter than me.
Any other questions? Well, thank you for the panel and all the panelists this morning. We're going to break for lunch, but don't be late. 1 o'clock we come back, and we're going to hear about improving existing therapy.